the noon hour. We're going to go ahead and start recording. Oh, Angela, you're one step ahead of me. We wanted to welcome you and all acknowledge that it's kind of a dreary October day. Please take care of yourself during this hour. If you need to eat, we encourage that. On camera or off, you're welcome to eat in front of us. That is a Zoom etiquette. This is our third learning series. I'm Brina Holmes. I'm a pediatrician. I think most of you know me by now. I'm here with my great colleagues at VCHIP, Julie, Angela, and our new data person, Courtney. Give a little wave there, Courtney Devlin. We also have our health department colleagues. We've got Cindy and Elena and Katie. So you're well supported. We're going to do next slide. This is my favorite slide, this one where we have to remind people about the Zoom rules, but we do it at every talk because repetition is fun. So we're intending a very interactive call today, including a breakout room. Do not panic. I have been to meetings where we've been sent to breakout and I think, no, 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 I just wanted to listen today, but I promise it'll be brief and painless. But we want to hear from you in the chat. It would help very much if you could pop in your name and your hospital, as always, in our continued effort to know the reach of our calls. We want you to unmute and talk to us as needed. If you need captions, there's instructions on how to do that. And then please stay. We will end at 12:56 so that we have 2 minutes for the evaluation. This is a quality improvement organization and project, and we have to hear from you because we are in constant state of needing to pivot and improve and rethink how we're showing up for you in this space. Thank you. Next slide. Okay, here's today. We are going to continue to welcome you as our great partners. I'm going to take us through just a couple of the education tools, recognizing that you've heard this before, but we like repetition. We're grateful our Northwestern Medical Center colleagues are here today. They prepared some nice slides to describe how they're doing this work. Hope that you can take something away from their experience. We'll pop into breakout by hospital. We're going to have 2 hospitals per breakout room with one of the 6 of the health department and the VCHIP team with you. We just really want to get to it and say, okay, we've told you a lot. We're talking at you a lot. What's working, what isn't, and how are we going to move forward? And then we're going to end by talking about why we do all this and why it's so darn important that you put so much effort in this space. Just one example of the many ways we use this data. Next slide. Okay, too much on this slide, but here's what we've learned from you. Establishing multidisciplinary teams is key. Identifying the best source of information and where on earth this data is in the record is key. And that's really developing instructions for the health information managers because we're talking about 2 different fields here. We're talking about clinical teams and we're talking about people that are very skilled and detailed in understanding data. Those 2 things don't always we just need a lot of communication and clarity. Modified electronic medical records continue to be of some help, but as we know, we all have different records and it's hard to standardize that. We want you to continue to know that there are resources available for you, and we really want you to tell us what definitions don't make sense. We want people to be trained in this. We know our health information managers are trained and understand electronic birth certificate, but we need our clinical staff to consider that as well. And then we know that this works best when we have identified experts in State Vital Records Department for the staff to contact. And that's all of us on this call, not so much me, but others. And then remembering that we have a lot of turnover, we have a recognition that as many hospital staff as possible that understand what this effort is important. Next slide. Okay, a review of the education resources. And then I'm going to give you warning. I think you pronounce your name Arina from Brattleboro has a little bit of an example here, but next slide. The resources that come from our CDC colleagues are excellent. So this first guide, the essential guide to completing the facility worksheets, is where you'll find your definitions, your instructions, your sources, and your keywords. And this is a free spiral bound copy, and you can also find it electronically. Births at cdc.gov. Next slide. And then there's the free training. And this is where we wonder, we know that all of the new EBRS users complete this training as part of their onboarding, but we really wonder if the clinical staff wants to do this as well. So I'm curious if, there she is. Am I pronouncing your name right? Hi. Okay, Erin is going to tell us what Brattleboro's done.
Hi. When we recognized how challenging our data collection was with our birth certificates and trying to get some level of accuracy with what we were submitting, I went on the hunt for what might be available for some training programs and did come across this one through the CDC. I assigned it to all of my nursing staff and all of my secretarial staff. We are the ones who do the data collection for both the facility sheet and the parents worksheet. It gets handed off to our HIM department, who verifies a few things, and then they ultimately enter it into the electronic database. So they really need us sending down as complete a form as possible whenever we can. So our electronic medical record can be a little challenging to find all of the parts and pieces needed. We did do the online training, and I would say that it best accomplished reminding folks of why we collect the data and what the data is used for. And so I think that there was a benefit in participating in that for those reasons, understanding that a lot of the funding for specific projects related to obstetrics comes from that for neonates, et cetera. And also understanding that the data that comes out of there is also used nationally by the CDC to set benchmarking, et cetera, et cetera. So that they had a better understanding of why it mattered that they were putting correct data into it. What it did not have was a ton of great descriptions for some of the various pieces that might be a little bit confusing when filling out the forms. So I don't think that it offered us that type of information that could have also been helpful. I know that the resource, the little binder that you were describing before, does go into some better detail on figuring out how to answer some of the questions when it gets confusing. So,
Well, Erin, at that, thank you so much for that, because the specifics and what we learned from the last call remained confusing. We've really sought to clarify in our chip sheet. So I feel like between the national resource and our local Vermont resource, we're going to cover this very well. So I'm going to show
we
you that
did
in 2 seconds. Yeah.
I'll say real quick, we did have a semi-confusing case with surrogacy and parents that lived outside the country. And I'll tell you, calling Vital Records, they were really quick and wonderful to answer questions and gave us really clear answers, made sure we had the right forms. So they were a surprisingly excellent, timely resource for us to answer some questions. So I would advocate for that as a route,
Yay.
one in question also. So
Hey, that's a nice
yeah.
shout out to our pals at the health
Yep.
department. Thanks, Erina.
Well,
Okay, next slide. Just a couple more before we get to our Northwestern colleagues. So, this is just that ongoing reminder that it takes the village here. The providers have to work with the birth certificate folks, health information managers, to figure out where the information is in the chart. And then best practice recommendations, we have to continue to remind people that the history and physical is a great place to start when the admission H&P, history and physical. There is this very specific ongoing body of questions around whether or not a condition was pre-existing or something that was developed, that a patient developed during pregnancy, and that is our tip sheet starts to flush that out a little bit. And then really understanding where's this mutually agreed upon place where the health information managers are going to be looking for the clinical information. And then from the birth certificate abstractor side, look in the designated areas, also recognizing history and physical is a great place, and then working on the mutual. So what this is, next slide, is Brina's favorite thing, which is team-based care. We are good at this in healthcare when it comes to things like trauma and cases, and we have to be as good in the teaming and the attention to the team in areas like data. So establishing a multidisciplinary team would be our wish, and many of you have that. Setting up a frequency of meeting. What is your, not just waiting to get this thing right, and then 5 years later you look back and say, oh, we got to get back to the matter at hand here. Figuring out how to share your experiences in a more frequent way will lead to better data and better relationships. And then just really slowing down a bit relationally and acknowledging that everyone on the team has expertise. And in the pursuit of a shared accuracy, you're going to find a lot of relationship strategies. People really do want to do well in their jobs. Next slide. Okay, I don't know how Angela wants to do this in terms of each one of you is going to have this resource from us. It might have already gone out. I think it did this morning that you will have a hospital-specific tip sheet for completing your birth certificate. And I don't think it works on this slide, but if we shared screen and showed you the tip sheet that I'll reference your email this morning, in the colored far right is where we provided the expertise and answers from call number 2, when we not only had our clinical folks on and Marge Meyer, but we also had our folks from the national vital records who were able to then come together after to see the clarity of your questions and to answer them. So, Julie, do we wish we were sharing the tip sheet, or is it good enough to tell folks to just look at their email?
Yeah, and if folks have not received it, please just add your email in the chat and we'll send it to you right now.
But the specific example would be that we really spent some time trying to figure out some of the very unusual cases that come to you about not knowing someone's last menstrual period, the very sensitive and vulnerable information about people wanting to not discuss previous pregnancies that may have ended in termination. There's an important sensitivity to this that we have really tried to outline for you in this tip sheet. And I'll say one more thing in the spirit of inclusivity and equity. The CDC knows that their language around pregnancy using the term mother is outdated, but it is a bit of a big ship to turn in order to update all of their language. So we don't show up using the word mother anymore, but the tip sheet still does. So that gap is acknowledged. Okay, next slide. I am thrilled to introduce our colleagues from Northwestern Medical Center. I'm going to hand it over to Anna and Bailey with a lot of gratitude and hope that their technology works. And Angela will advance the slides for you. Thanks for sending them ahead of time. Welcome.
Thank you, Brina. Hi, everybody. Thanks for inviting Bailey and I here to kind of show our process at NMC. I think it goes pretty well from a clinical perspective. It's pretty easy. So my name is Anna Gabry. I'm the director of the Family Birth Center.
And I am Bailey Martin. I'm a health information technician and one of the lead techs to complete the birth certificates here.
Wonderful. Next slide, please.
So here we have 4 health information technicians, 22 RNs from FBC, 6 OBGYN providers, and the families who have given birth. These are all the people that are part of the birth certificate making process.
Next slide. I think you guys are all familiar with the workflows that VCHIP has worked with us to outline. So what we'll do here is we'll quickly review and then go into a little more depth as we move through our presentation. So essentially our process starts when the birthing person is admitted to the family birth center and the baby is born. The FBC nurse will distribute the parent worksheet. The birthing person completes it. Birthing person returns the parent worksheet to nursing, and nursing literally places it in like a binder. And then from the physician end, which I think is super slick, the FBC providers complete the facility worksheet, which is built within their EHR.
Yeah, and so from that folder, HAM will go and pick it up in all other pertinent parent worksheet information in the birthing center. We will then bring it back and HIM will gather and enter all the parent worksheet information to the medical record. We will then retrieve facility worksheet information and make the birth certificate, the HIM one. We will also gather information from the MD birth certificate and any other pertinent information, and we will use that and put it on our HIM worksheet, which I will show in the next couple slides. We will then enter all of that information into the EBRS system and submit to VDH and scan all of the other paperwork into the birthing person's account.
Next slide, please. So here on the Family Birth Center, it's been kind of interesting for me working on this presentation with Bailey because it feels from a clinical perspective like it's relatively easy and slick. So I wanted to show you some of our tools. You can see here on the right-hand side, we have a screenshot of our work list. So every 8 hours, we have a reminder pop up to collect the worksheet from the parents. And then within that intervention, you can see on the bottom, we can document if it's been given or if it has been completed and on the chart, which I think is really helpful, a helpful reminder. So again, the parent worksheet is built within our admission folders. If someone comes in for scheduled induction and things are going slow and it's appropriate, we'll start reviewing that form with the parents prior to delivery. And if it's not appropriate, we'll wait until after delivery. The forms are discussed with nursing and the family. And then upon the parent completing the form, again, it goes into that binder and then HIM picks up the forms from the binder. So super easy. And I like our reminders built within our EHR. Next slide, please. And then this, I think, is one key element to our success in our data accuracy here at NMC, the data that's extracted and pulled for perinatal statistics, et cetera. So this is the provider documentation screen that's integrated into the EHR. It's starred in their favorites list, and then upon delivery of the infant, the provider fills it out. So it's a part of our system now, and nursing doesn't even think about this form. And it's an interesting point of education for our new nurses coming in for gestational carrier pregnancies, et cetera, that we do need the other form, the paper form, that there is a second facility worksheet form because it's so seamless at this point. Next slide. And then from there, it's all HIM.
So this is our HIM worksheet with our little checklist on there. We use this worksheet to gather all of the information from the parent's worksheet and from baby's electronic medical record and the birth parent's electronic medical record. All of that information we use to put on this sheet. And if you see in that bottom right-hand corner, there's a little checklist that we use. We use that checklist in an order to ensure that nothing we are doing is getting missed and everything is getting scanned into birth person's chart. And next slide, please. Okay, so our internal audit process. So we put baby and birthing person's information into the baby spreadsheet that we obtained from FBC's birth log binder. So every morning, HIM will go over to FBC. We will check that binder and write it down. We will write down birth person's name and date of birth along with their medical record number, and same for the baby. Sometimes we get that information before we get the paperwork. So we will add that into our spreadsheet to make sure we are looking out for that paperwork for those people. We will then utilize that checklist that I just showed you in that last slide. Our HIM technicians review both the worksheets, content, doing a chart review to ensure all the information needed is there. We will then create the HIM report in the birthing person's EMR with the info we have gathered from both the parent's worksheet and birth person's EMR. We will then check birthing person's personal insurance regarding Social Security cards. So if birth person has Medicaid, they will get a DSW with a DSW letter. If they have any other insurance, including self-pay, they will just get a non-DSW letter only. We will then begin the birth certificate process through the EBRS website. We will then print off that draft birth certificate along with submitting it into the system. Once we have that birth certificate printed off and the DSW paperwork printed off, we will scan that into the birth person's chart.
Hey,
And then we
Bailey,
will, yes,
can I just interrupt for a sec? Folks are asking in the
sure.
chart, what is DSW?
So DSW is for the insurance. So I personally don't know what it stands for. I have never been informed of what it stands for. But we use those primarily just for Social Security cards. It stands for Medicaid insurance. So those forms will tell birth parent what to do with their new baby Social Security card. They will bring it to the Medicaid office, and that is how they will get the Social Security card for their baby.
Awesome. I'll put something in the chat that I found from Googling. Don't you love abbreviations? It's so funny.
And
Okay,
this, I
thanks.
can
Sorry.
send this along. This is a form from the state, I believe, which
Yeah.
the nurses will sign as well. So they have proof of birth until they get the information.
Yep. And then as long as the baby has been discharged from the hospital for 24 hours or longer, we're able to update their name to their birth name that birth parent picked. We'll update that into the system. And then our Excel birth log spreadsheet that I'm going to show next, we also update that as well to show that we have completed the birth certificate. Next slide, please. Okay, so this is a little snippet example of our spreadsheet. So our spreadsheet includes baby's date of birth and their name as it is across in our medical record system. We also have mom's medical record number and baby's. The date we did the interview and printed off. So that is the date that we started and completed the birth certificate. We will also put down if they have filled out a parentage form. So if they're not married and second person wants to be on the birth certificate, they will fill out that form and we will send it off to Vital Records and they will put them on the birth certificate. We will also put parent's phone number, DSW if they have one, baby's weight, newborn account number, their name and Meditech. If we have updated that, we will put it there. Also, if we have scanned all of the important paperwork into the birth person's chart, we will also write that off there. And that HIM and MD birth certificate worksheet that we use in the EMR, we will write who completed that. And every parent's worksheet has a question that asks if they want a Social Security card issued for their child. That on here, we put a Social Security card, yes or no, and that's for that. Sometimes we do not get information regarding birth person's last menstrual period. So if we cannot find that in the system and we're not able to log that into the EBRS website, we will put an additional comment stating that. We will also use this spreadsheet before we have even received the paperwork regarding birth person and baby. And we will log the medical record number for birthing person and baby's date of birth and current name in our system. We will then review the labor log daily to ensure all the patients on the spreadsheet and nobody gets missed. So for gestational carriers in the spreadsheet, we chose to highlight to kind of show that that's a different type of birth certificate. Unfortunately, I have not had the chance to do one myself because we don't get that many. But for them, gestational carriers, they get highlighted in the spreadsheet. They their information gets scanned into the intended parent chart and not scanned into the gestational carriers chart. And we make sure that no gestational carrier information gets scanned into baby's chart for various reasons. And then all of that paperwork gets mailed to Vital Records, and they complete the birth certificate on their end and all the paperwork. And next slide, please. So our compliance with 5-day reporting, NMC was at 100%. It is now down to 98.3. Reasoning for that could be staff turnover and new team members. As when we get new team members, we knock down another person to do that training. So it can kind of get a little hectic with that, but we are ensuring that we're staying at 100% now. Next slide, please. So the pros and cons of our approach, our roles are very well defined. It's easy and seamless for the providers to kind of figure out. All of our technicians' processes are very clearly laid out. All of us understand it very well. Our spreadsheet ensures technicians are prepared for every baby born before receiving parents' birth worksheets. And the checklist makes a huge difference, making sure nothing is missed. The cons for this is sometimes nursing can forget to collect paperwork forms, especially if a patient leaves AMA, it's kind of the last thing on their mind. And occasionally parents do take their worksheet home, which when this happens, HIM will reach out to FBC first to see if they have it. If not, we will contact the birth parent and make sure that they come in and refill out that form or give us the filled out form before the deadline to get that birth certificate in.
And to kind of validate what Bailey has just described, I've said it a few times, it's pretty easy from a nursing perspective and from a provider perspective. When we started this project, it was kind of like, well, I'm not really sure because it just happens behind the scenes. And definitely staff turnover from a nursing perspective. We're reminded every day on the work list, have you done it? Have you not done it? But particularly if there's some sort of a situation happening with the patient and there's a need for a rapid discharge, that's probably the last thing on the nurse's mind to try and collect before they go. So that, you know, we have missed related to the reporting deadline, occasionally patients' parents taking the form home instead of nursing collecting it. But yeah, it seems to work pretty well.
Well, I learned a lot, and I'm curious. Thank you so much, Bailey and Anna. I'm curious if folks, we have a few minutes, if folks want to come off mute and ask questions about what you just heard, or if you're still processing. I know that NMC would share any and all of those forms with you. I in particular am curious if other hospitals have that workflow reminder on their EHR that Anna outlined at the beginning. That seemed pretty slick in a good way. What did this bring up for you? I think in the spirit of learning community, we'll share Anna and Bailey's email with you because it's such a wonderful small state when we, and by the way, Bailey, I don't know you at all, but dropping from 100 to 98.6 is probably not statistically significant. So please don't. Oh, Audrey. Hi, Audrey. Yeah, nice use of the hand. Audrey has a question.
Hi, thank you so much for your presentation. This is really interesting, and I was curious. I know that you mentioned that it's very rare to have surrogates, and I was curious if you could talk a little bit more about where their information does go, since it sounds like it does not end up in the child's birth certificate. Yeah, thank you.
Yeah. So essentially we get all of the paperwork the same way we do for regular carriers. So we will pick it up from FBC We will bring it back to HAM. We'll gather all of the information like normal, but nothing gets scanned into the charts. And there's certain reasons for that, as maybe the birth parent does not want gestational carrier's name or anything related to that in their baby's chart. Some parents just don't want their child to know that they didn't carry them. That's okay. So we just make sure that nothing from that gestational carrier is put into the baby's chart. We do put some of that information into the birth parent's chart. So we will scan in like the parent's worksheet, so the name and everything for that, we will scan into the parent's chart. But everything else gets sent to Vital Records and they complete that on their end for gestational carriers.
Wonderful, thank you.
You're welcome.
And to clarify some of the pertinent medical information, blood types and stuff, there are components that are in the baby's chart, and this is specific to the birth certificate naming convention process and what is scanned in and what is not related to the birth certificate. And there is documentation within each person's chart that it is a gestational carrier pregnancy. But the vital records piece is separate.
Rena, you're muted.
It's such a cool world that we're allowing all sorts of complexity, right? I really like the work in that space because it's a much more inclusive world to consider all the different ways that babies come on the earth. Lots of cool examples. Okay. Please know that there's much more to learn from NMC real time because it's a little hard to hear it and then wonder how you're going to implement. I did want to note from Cynthia that CVMC doesn't appear to have any of those nursing reminders. So that in particular, as a clinical person, Brina, that popped up for me because we all know what real life healthcare delivery feels like, and reminders are a great quality improvement strategy. Okay, we've come to your favorite part of this session. We're going to breakout rooms. Here is what we're going to do. I'm putting it in the chat. We're going to go out into rooms. We're going to introduce ourselves. We're going to wonder what's still going on out there in the world for you, what's working, what isn't, and where do we need to continue to dive in as your quality improvement team. So Angela has been working hard to get us into groups by hospital, and she's going to open the rooms now. Do you guys know how to find breakout rooms? Sometimes on my computer, you have to click more, ... and it says join breakout room. Oh, she didn't have to figure it out because you just go where you know you. Angela's smarter than I am.
Hey, Katie.
Hi, no one was in my breakout room.
Okay.
So I just was like, I'll come back and check out what's going on in the main room because I wasn't sure if
Cool.
I should go back and just hang out and wait, or if everyone was having issues, or if it's just me. That sounds like it might have just
I
been
think it's
nobody
just
from that
that,
region.
yeah, I think it's just that room that doesn't have anyone
Okay,
else in it. Do you want to go into a different room?
sure. I'll just join one of the other ones. I'll join the Central Vermont one because it looks so small. Oh, Southwestern. I'm just gonna join one randomly.
Cool.
Oh, wait, that's now it looks like there is one person in. Then let me go back and look.
I think it might just be you.
Oh, okay. I did exit it. Well, should I go back in,
You
check
want
it
to
out?
peek just in case?
Yeah, okay.
And just in case I'm not seeing something. Okay.
Yeah, it was just me.
Okay, cool.
I'll just join one of the other ones.
Okay, awesome. That sounds good.
Oh, actually, Angela, I have a question for you. Am I coming back? Am I doing the next two slides? Or I had gotten my name was on the breakout session slide and then the two coming back in, but is that still the case, or should I Julie had sent me a slide deck last week. I just want to make sure that I'm not.
Let me look on the,
I have my name is on
yes, it is you coming up on the next one.
2220. Okay. All right. Just want to make sure. Okay. All right.
Yep. Okay.
Okay. Everybody survive? I think we had a little tech thing, right? We didn't populate and we had to move, and I do think we lost some people. So we have a few minutes here. We'd love for folks to say what you talked about. And I was in group one, and I'm gonna put Cynthia on the spot because she just came to something pretty important. And then yeah, we'll start with Cynthia. I think you're muted. But your hand is definitely up. There you
Can you
go.
hear me now? Okay.
Yes.
All right. So one of the things that we have for a big challenge at CVMC is the question on the facility worksheet of, I think it's the facility worksheet. Gosh, now I have to look to see which one it is. It is the question of how many other outcomes there have been. we don't have much trouble getting last births information. That seems to be readily available. It's really just the last outcomes that is hard. So we really would love to see our Women and Children's Unit really hone in on that question, because that's not something that we could just make a quick phone call and say, can you clarify this, such as social security number or something like that, that we do have to do.
So the reason I love that
well,
example, and just for the group for time, do you see how the health information manager can't do that without the clinical team? That wouldn't be appropriate care for a
Yeah.
really skilled data and health information leader to have to call a patient with whom she had no relationship. So perfect specific example, and happy for Northwestern as well, that just being able to call the clinical team and saying, hey, we have a unanswered question and you know how important this birth certificate is. Can you help us? Is a takeaway from today. Okay, what
I have a
else?
question about that because we were talking about how we do it. I do home birth, I was sharing, but we usually collect that in the beginning with like their health history. So I was just curious if you know, Cynthia at CVMC, like what the process is like, because that to me seems like the most appropriate time to collect that is when the person is coming into care, when at their first prenatal appointment, going over their history, because I do think even, I mean, yes, of course, like somebody at the hospital who's there, but even right after someone gives birth, that seems a little awkward or inappropriate too to me. Like to me, it seems like their very first prenatal, there should be some way to go over their history and get that information if possible, if you're trying to integrate that feedback into
Yeah.
your practice.
Yeah, Allison, that's a great point. We were really lucky to have Allison in our group because we didn't have the clinical folks from CBMC with us, but that's something to explore. I think we've talked about some of the challenges of getting the prenatal record into the hospital care, which is another quality improvement strategy that has a different solution in every hospital based on your record and how on earth you're going to get that. I did want to just say, because Cynthia's so great that she just reiterated a sentence that we can use moving forward, which is face-to-face conversations with the clinical teams. So that's that meeting structure that I'm really curious about. I am not trying to add another meeting to your busy lives, but if this relational piece really matters. So, and then Reagan was also on our group. She said clinical will many times capture, yes, they had 2 other outcomes at the initial but the date is blank, right? So it's the incomplete nature of the prenatal record that gets us in trouble, and that Cynthia's noting we search initial prenatal visits as well as all others if needed. We even research older scan record. I mean, they really work hard on finding it on the health information side. But you shouldn't have to do that much work because you have someone clinical maybe 15 feet away. No, maybe 600 yards away. Many of you know I worked at Porter Hospital. Alicia knows that. And it used to be very far because the person was in the attic. Okay. Other thoughts? I think I saw Bailey's hand go up. We're going to just do one more share because then we have our great colleagues from the health department to take us home here. Did you?
Nope,
Was
I
that
think I'm
Bailey?
good.
Okay. What else happened in groups? Oh, Sarah, you're still in the attic. I didn't know that. I would think with all the construction you would have moved. Well, I'll come visit you sometime.
No.
Old memories. Oh, Anna and Bailey, question for you. Can you clarify that you're using Meditech? Is that your EHR?
Yes.
Yes.
Well, that's good for you, but not great for us because there aren't very many hospitals using it. So I'm not sure you can. But
No,
I'm interested in
so
exploring a prompt, right? For the nurses. I like prompts.
yeah, that's been very helpful. Especially like for me and maybe for per diem nurses, like I'm not always at the bedside, and so it's like, oh shoot, yeah, I gotta go look at that form and make sure that's done.
Okay, well, we are getting so many quality improvement strategies in this chat. Cynthia just revealed to me that she's actually a few miles away. I mean, my goodness, if that isn't fraught. So this shows how just the idea of coming together in a conference room is actually has a barrier. And so the idea that you can't just pop downstairs and say, I can't find this is now back in my consciousness. Thank you, Cynthia. And then Heather's noting it's hard to convince clinicians that birth certificate information is more important than all the other clinical concerns, which is so true. And that is why, and I heard Anna say it, it's right there as a reminder. And then sometimes it goes whoop down to the bottom of the to-do list because it is, not obviously as acute as the healthcare. But part of the reason for the training and the ongoing energy of, oh, right, we have that quarterly meeting, or I got to go see my friend Cynthia, is to put it back up into the reminder field that this is how we move mountains for pregnant people in our country. This is how we get federal funding and state funding to do something different in the care. It's not fluffy, I promise. It's very important. Okay, and Cynthia uses Microsoft Teams. I'm so glad you all came on today. So the final presentation today is from our health department colleagues who are going to tell you how they use this data in the maternal mortality review. So take it away. I think it's Audrey.
Oh, thanks. There was actually one
Oh.
more slide back. I'm just gonna, can you go back one slide? Just to show this, we're not gonna have time probably to get into this, but we do want more feedback if you guys have it on birth certificate worksheets, some of these VAP processes that were brought up, Department of Health quarterly report that you all receive, if you have feedback or questions about it or anything else for our vital statistics partners. We want to hear from you guys and to hear some feedback. And I'm going to turn it over to Audrey, who's here to talk about one of the ways we use your birth certificate data, which is on the maternal morbidity and mortality surveillance.
Hi, everyone. My name is Audrey Ling. I work at the health department and I sit in the health statistics and informatics division. And one of the grants I work on is the Maternal Mortality Review Panel. And we use birth certificate as well as death certificate data to help us identify and then review cases of maternal mortality. Yeah, could you go to the next slide, please? Katie, did you want to take this one or?
Sure, I'll just really super quickly. It's been around a little bit over a decade, and we come together as some clinical and community partner professionals to review cases of death during the pregnancy or 1 year postpartum from any cause to Vermont residents. And then we create recommendations for prevention of future death. So the data that's reported to us, we use that to create a picture of the person who has passed away and then to prevent future death. So it's pretty important.
Thanks, Katie. You can go to the next slide. So I thought I would start off by talking about some of the data points that we use to assess maternal mortality. So one of the things that we look at is the timing of the death, whether that happened while the person was pregnant or the day of delivery, within 42 days, or between 43 and 1 year of delivery. So here we can see that there are some discrepancies between Vermont and the nation as a whole. In Vermont, we see much more of those deaths later on. Next slide, please. And then another important factor in maternal deaths is race and ethnicity. We know on a national scale that there are some very severe disparities. In Vermont, with our smaller population and our racial demographics, we are unable to say at this point in our data collection whether or not we see those at a statistically significant level. However, just understanding how things work at the national level, these are likely at play. We're just not able to detect them yet with such small numbers. And then the next slide. And then Katie, I don't know if you wanted to take this one and the next one.
Sure. Yeah, these are just some slides. You guys can review these later. We just wanted to give you an idea of the perinatal mortality situation, which is heavily substance use and mental health involved, which may not surprise any of you, I'm assuming at this point. So we can go to the next slide. And again, this is talking about the mental health and the suicide as main cause, with 11% there as well. And then we see the other types of comorbidities that also happen with these cases. So this is a little bit of data just to show you, so we create as full a picture of the lives of the people we review as we are able to access. So next slide, please.
So a brief overview of Vital Statistics. That is a data source. It is CDC funded, and it is updated daily. However, there can also be a bit of a data lag. The final data is available 1 year following the completion of the calendar year. And some of the data included that we use specifically for this is all of the birth and death data which occur in Vermont. So that could be of an out-of-state resident as well. And then we also get birth and death records of Vermont residents that occurred out of the state. However, we have much more limited information that we are allowed to use for out-of-state occurrences. Yeah, next slide, please. So part of our death identification process, there are 3 main ways that we do this. First, there is a pregnancy checkbox that is on the death certificate. So whoever's filling this out, which could be the medical examiner, the funeral director, and or family member, they can indicate if the decedent was pregnant and what timing their pregnancy was in relation to the timing of their death. So this isn't always accurate. So we do have other ways that we try to identify deaths. Some of those being that we search the cause of death fields, both the ICD-10 and the text fields, for pregnancy related codes and or words. And then we also link potential deaths with birth certificates. So even if we do identify those deaths with the pregnancy checkbox, we still need to be able to link those to the birth certificates. And then we also check all potential records against each other so that we make sure that we're capturing all of those records. And the way that we do that is through a variety of variables that are present in both the birth certificate as well as the death certificate. So the birthing parent's social security number is present on the birth certificate as well as their name and date of birth. And then you can go to the next slide. And then we have a software called Link Plus that is provided by CDC, and we input these data files, and it essentially runs and looks for matches between the 2 different files. So this allows us to verify a case that we have identified and clarify that the date of death was within 1 year of the date of delivery. It provides additional information, including birth weight and prenatal visits. And then it is really helpful because there can be entry errors as anything where humans are involved. So for example, with the names, there is a phonetic system that it's comparing. So it's not only based on spelling. The name can be written out a couple of different ways and it will still potentially flag that. And we're also looking at social security number, as I previously mentioned. And even if it's not an exact match, where I have seen some typos in social security numbers, it will still come up in a match. And then all of that gets manually reviewed. If there's
Audrey, I'm gonna stop you there just for time. I'm so sorry. I think you're on your last slide, but I wanted to make sure folks had a chance to do their eval. So I wanted to just absolute thank you for the depth of information here. I hope it was inspiring. And I guess there's the last slide about why this is so important. We need a minute at the end for evaluation. So I wanted to be really grateful and thankful for all of you and your continued effort in this space. I wanted to thank Bailey and Anna for giving us a Northwestern example, and to Audrey and Katie And Ellen and others who are working so hard on the maternal mortality space, it has really been an important catalyst for our efforts and knowing where we need to. Vermont is known to be quite a healthy state, but we have some very glaring areas. Wait, the slide just before, we don't want to miss a chance to see you one more time, November 4th. You can see how fun it is. We can't promise there won't be breakout rooms there, but this is our chance to come together one last time in 2024 and keep talking to each other. I know we didn't get a chance to debrief the breakout rooms for everyone's group, and we learned a lot from you, as we always do. So please join us November 4th at 12 o'clock. And the last slide, with 60 seconds to go, there's your QR code. Are you all skilled enough to pull a evaluation off a QR code? Because I'm 50% on that one. There might be a way to put it in the chat as well, but I don't want to overpromise. Well, we're going to end with that. I'm going to be quiet. Oh, Julie's the best. Call evaluation in chat and QR code. I will now be quiet and leave it open so you can evaluate us. Grateful for you.